and welcome to today's webinar series from GE. Today's topic is Intelligently Efficient MRI, brought to you by Recon DL. My name is Anya Brau, and I will be the moderator for today. I'm the General Manager for MR Clinical Solutions and Research Collaborations at GE. And I'd like to remind everyone that you can submit questions in the Engage tab, and those questions will be answered at the end of the session by our panelists. First, I'll start with what is Recon DL? Well, in my opinion, this is the most exciting technology I've been involved with in the last 2 decades. And what it is a deep learning-based reconstruction technology that intelligently removes image noise and image ringing from the final reconstructed images. And these are artifacts that we've typically come to sort of accept and live with in MR conventionally. But now those artifacts can be removed, which delivers sharper and clearer images than we've ever seen. And this improvement in image quality, in turn, enables shorter scan times because you don't need to scan as long to get high SNR and high image sharpness. So how does Recon DL work? Well, it uses a deep learning network embedded into the image reconstruction pipeline. And this network has been trained to reconstruct images that are sharper, thanks to having access to all the raw data, as well as having higher SNR with a user selectable improvement level. And this reconstruction process happens right at the scanner immediately after the scan is complete. And Recon DL is compatible across the body in all anatomies, as you see here. So to give you more of a flavor of how Recon DL works in practice, we are going to hear from a number of speakers who have Recon DL deployed in their clinical facilities across the globe. Let me introduce our speakers now. First up, we have Dr. Melanie Atkins, a radiologist from Fairfax Radiology Centers in Fairfax, Virginia, who will speak about image quality and resolution improvements in her practice. Next, we have Dr. Christopher Ahlers, radiologist and CEO of Radiomed in Wiesbaden, Germany, who will speak about the ease of use of Recon DL. Next, Dr. Larry Tannenbaum, who's Chief Technology Officer, Director of Advanced Imaging, and Vice President of RadNet, will speak about productivity improvements that he's seen with this technology. And finally, Dr. Randy Stenoien, owner and CEO of Houston Medical Imaging, will speak about productivity and return on investment experiences that he has had in his site using Recon DL.
Hello, my name is Dr. Melanie Atkins, and today I'm going to demonstrate some case examples of improved resolution, image quality, and SNR with Recon DL. This is a case of a 70-year-old female patient who has metastatic cholangiocarcinoma. And this is an example. On the top images, we have conventional image reconstruction. You can see here with our routine matrix slice thickness at 2 necks, we have adequate image quality. As we increase the resolution when we increase our matrix size, we did decrease to 1 next here, same 5mm section. You can see that we have introduced some noise, but with the improved matrix, I think we can start to see this very subtle liver lesion here at the tip of segment 6 of the liver. And then when we increase our matrix size again to a super high resolution image, thin slices at 2.5 with the same necks, you can see that our image quality really struggles secondary to our low SNR. But with Recon DL, we really don't have these issues. So we can use these super high resolution images. And I think you can appreciate here with excellent image quality, we can see this subtle segment 6 liver lesion even better. And when we even look further into the rest of the liver, I think the image quality you can see when we utilize Recon DL is much improved. This is a 91-year-old patient with dementia who really struggled in the MR scanner. And so we tried to do rapid imaging for this MRCP. And you can see here we did some 2D thick slab MRCP images with conventional reconstruction. And although we can see our diffusely dilated pancreatic duct, I think we can all appreciate significant improvement in image quality here, all the way to the ampulla with utilization of Recon DL. With small field of view pelvic imaging, we really get value with AIR Recon DL. One of the things we struggle with in our small field of view pelvic imaging with super high resolution is long scan times. And before we had AIR Recon DL, we often saw these 5 to 6 minute high resolution T2 sequences. And we often got organ blur because of the long acquisition time, secondary to motion in the rectum, or motion with the patient. So now with when we decrease our next to 2, we've got a just over 2.5 minute acquisition time, low SNR on this image, but no issues with organ blur. And I think you can all appreciate that the image quality utilizing AIR Recon DL in a third of the time is really far superior. The same story is within the rectum. You can see here, this is a little over 4 minutes on this image, and there's just some organ blurring and likely from rectal peristalsis. And so when we do a much quicker image here with conventional reconstruction, obviously we have very low SNR, but with utilization of AIR Recon DL, we have the best of both worlds, really excellent SNR. You can really see the edge of the tumor extending into the mesorectal fascia. This is the same patient on a coronal image. Again, we have similar problems with organ blur here, secondary to rectal peristalsis. But when we utilize a much quicker acquisition, we have excellent image quality here with AIR Recon DL. Same story in this case of a perianal fistula. I think you can appreciate when you look at conventional image reconstruction as compared to the bottom 3 images, we have significant improvement in SNR, looking at the anal sphincter complex here with the internal and external anal sphincter. We have the sinus tract extending posteriorly. And again, with our fat saturated images, you can see excellent image quality of the sphincter as well as this sinus tract. And our post-contrast images, I think, again, demonstrate similar findings. A similar story with cervical cancer. This is another example of a patient. We were able to decrease the scan time to under a minute for all 3 phases. And I think you can evaluate the perimetrial tumor extension in this case much better with AIR Recon DL. This is just the coronal of that same patient. And again, I think you can see far superior image quality and SNR here with AIR Recon DL. And again, 58 seconds compared to our conventional 2.5 minute acquisition time. I did want to mention that our musculoskeletal neuroradiologists are also embracing AIR Recon DL as well in all musculoskeletal and neuroimaging. And you can see here they're doing very high resolution imaging here in the shoulder as well as the spine. Thank you.
Hello, everybody. My name is Christopher Ahlers from RadioMed Wiesbaden, and I'm really happy to share our experience with AIR Recon DL. And I'm going to talk about the ease of use in my presentation. So AIR Recon DL, how to easily use it. Most of it's about protocol optimization. So when we use it, we normally start off from the point of optimizing pulse sequence. When we optimize it for increased spatial resolution or improved scan time, we're likely introducing some noise into the resulting image. And this noise actually is being removed by using AIR Recon DL deep learning reconstruction in order to regain the signal we lost or even improve SNR. And this is a screenshot from the scanner console, and I just wanted to show you how to easily switch on the deep learning reconstruction in the advanced settings tab of the pulse sequence. You just select the drop-down menu to switch AIR Recon DL to low, medium, or high. And you can even choose to keep the original images to compare or for reference purposes. And this is what the reconstructed images look like. On the far left, there's the conventional reconstruction, and then the 3 strengths, low, medium, and high with AIR Recon DL in this quick series of a little more than 2 minutes in this knee exam. So another example is this hip exam, when we improve the original sequence in terms of spatial resolution and to increase the metrics, and also reduce the number of excitations to save some scan time, we introduce some noise, which we later on removed by switching on Recon DL. So basically the principle is always the same: modify the series and then clean up any mess you've made in terms of SNR by switching on Recon DL. Specifically in sequences that have an inherently high noise level, like for example stir, our observation is that we can drastically increase the contrast to noise ratio, which really improves lesion conspicuity. This is another example of a knee exam where we've improved the spatial resolution and decreased the scan time from the left to the middle image, introducing some noise and removing that noise by switching on the deep learning reconstruction. And with this technology, you can either go into the one direction and invest everything into spatial resolution, as in this example where we move to 2 millimeter slice thickness with 0.3 millimeters voxel size, or you can go into the other direction and do an exam with 4 acquisitions real quick in 211 seconds. So a Recon DL perfectly pairs with the air coils, and in long bone imaging, for example, specifically long axial stacks with high number of slices, like in this case 45 slices, come out really nice in a decent amount of time of 220 seconds in this case. And we can also enable new opportunities, as in this example of cardiac myocardial perfusion image, where we've increased the spatial resolution in order to decrease dog rim artifacts. And the example in the left side, where we've introduced a noise level that would, with conventional reconstruction, be unacceptable, we have a very beautiful image with a Recon DL on the right-hand side. And another application, just to show you a final example, in this case is a single shot, short axis acquisition and free breathing with no breathing command, requires virtually no cooperation from the patient, and we see quite good image quality and very nice noise level in these free breathing acquisition with a Recon DL on the right-hand side. So my conclusion in terms of ease of use is that a Recon DL shows impressive performance in reducing image noise and gip springing, and really improves SNR and contrast to noise ratio, and it allows to push protocols or applications to levels that would otherwise be incompatible with conventional reconstruction, and it works in any anatomy, and it largely avoids the traditional trade-off in MR between resolution, scan time, and image quality. And this is a rare situation where you're being offered the free lunch in MR. From my point of view, is the most significant development in MR technology over the last years. So I would like to thank you very much for your attention.
Hello, I'm Lawrence Tannenbaum, and I have the privilege, actually, frankly, I'm excited to have the privilege to share my perspective on where we are with AI and image reconstruction, focusing on the innovation that Recon DL has made. So when you look at this tool, you say, what is it? What does it do? Well, I think the top line message is it reduces image noise, and you can see the issue in this particular circumstance where we just don't get consistent enough wrist images in day-to-day practice. And you can see on the left-hand side, we're talking about using a 6-nex acquisition takes about 3 minutes, and it isn't quite getting us there on a routine basis. If we decide to try to accelerate this sequence and go to the right-hand side of your slide down to 2-nex, get it down to 1 minute, it's even worse. Notice, by the way, what the Recon DL does to the image on the right and turns it into a glossy, high-resolution, high curve appeal, and entirely more diagnostic image. And that's primarily what Recon DL does. we have conventional noise reducing schemes on our scanners, and we use them throughout our network to get some acceleration, but there are limits to what this can do. You can see from this particular example where we're looking at a 1.2 millimeter 2D fastband echo slice, it's really starved without any noise reduction. When we apply conventional noise reduction, we get, we make some progress, but that's not a satisfactory image. It's a little waxy, it's just not great. Look at what Recon DL does to that image. Makes it a sharp, crisp, frankly spectacular image, and really sort of opens up the opportunity to do thinner and thinner slices. One of the things this tool does is inherently sharpens images. If you look at the lower left-hand side, that's our standard of care routine axial wrist. It's a 3-neck study. If we try to accelerate that image by going down in necks and also reducing the matrix, it gets softer. Look at what Recon DL does to that accelerated image. It's actually sharper than the original image. So one of the tactics you can use to go faster is to drop the spatial resolution a bit and let Recon DL bring it back for you. You can see from this particular example where the image on the bottom is at 320 by 160. The image on the top is 320 by 180, so marginally smaller. Image on the top took 248, on the bottom 112. And just because of the reconstruction's ability to inherently sharpen, if you look at the cartilage at the patellofemoral joint, it's strikingly higher in resolution. You can see the same effect here. If you look at the cartilage of the joint compartment, it just looks roughly twice as thick. And one of the things that higher resolution does for you is it makes structures seem larger. Take a look at this example. This is the same example with and without the deep learning recon on it. One is the conventional recon, one is the deep learning recon. And you can see that the sharpness of the image is up, the contrast to noise is also up, and it's a much more pleasing image and much easier to read. One of the things that Recon DL does is it recognizes and reduces artifacts. If we turn the Fermi filter, the apodization filter off on our scanners, we will get truncation. We'll get some resolution back because typically this filter throws out some resolution. But we get this truncation. If you look at the left-hand side, you can see there's multiple lamellations within the cord, which are artifactual and truncation related. The Recon DL algorithm recognizes this truncation so that we can leave the Fermi filter off, take advantage of that resolution that we typically have to throw away to use the apodization filter, and also eliminate those artifacts. And this is really one of the biggest hidden benefits of the tool. If you look at these clinical cases where I turned the filter off, PD on the left, T2 on the right, zooming in on the PD, you can see the Fermi filter is off in both of these, but without the Recon DL, I get truncation. The image looks kind of lousy. The cord looks small. With the Recon DL algorithm, the cord gets bigger, the images get sharper, and of course, the signal to noise also improves. Another thing this tool does is it routinely elevates your image quality. You initially think of this tool as it helps me go faster, but frankly, it's going to elevate your entire imaging chain because there's such powerful noise reduction and such greater efficiency. This example is 248 on the left, 1 minute 10 on the right. It encourages you to go for higher resolution approaches, 320 by 180 on the left, 448 by 200 on the right. So a lot more speed lets you dream a bit more for loftier goals. And I think this is something you see across the board. On the left-hand side, believe it or not, was what we were apparently doing for our thoracic spines. On the middle frame here is our new approach. By the way, image on the left took 2 minutes. Image in the middle takes about 1 minute. But you can see the new approach has got a lot of noise because we've really bumped the resolution here with this rectangular field of view. Notice how spectacular the final result is with the Recon DL. And that is probably the best looking thoracic spine image I've generated, and it's generated in a minute, which is really remarkable. Another thing that this tool does is it enables techniques that you can use to improve the integrity of your image and reduce blur. What are the things we typically do? Well, if you look at the right-hand side, that's our target image. That's our manipulated image. On the left-hand side, that's our routine day-to-day image. And if you notice, we've gone to higher bandwidth. We've also reduced our frequency matrix, which also both of these factors reduce our echo spacing. We've gone from 2 necks to 1, from 118 to 41, but this tool allows us to use higher bandwidths because we can make up for the SNR, lower frequency matrix because it inherently sharpens. This gives us reduced echo spacing. As you know, blur in fastband echo images is proportional to echo spacing multiplied by the echo train length. The combination of reduced blur and the inherent sharpening of the Air Recon DL gives you a significantly sharper result. If you look at the subchondral bone about the tibio-talar joint, you can see that the image on the left, which was our standard of care, is softer than the image on the right, and it's even softer than the image in the middle, which is processed by the Air Recon DL. So these are really important tools for acceleration as well as improving the inherent image quality. Same thing here, bandwidth 50 on the left, 62.5 on the right, 288 frequency matrix on the left, 256 on the right, 4 next to 2 next, 320 to 134. Zooming in, if you look at that Achilles tendinopathy, it's just a little bit sharper. And by the way, 53% faster. So if you want to go even sharper, again, you can spend some of that 53% faster if you like. So what has this meant for us in our early implementation at one of our busiest scanners in Manhattan? You can see across the board, across the range of exams, we've run anywhere between 30 and 50% reduction, with probably the mean being around 40% in reduction. You can see the actual scan times here, and you can see the percentage decrease on the right, but perhaps most importantly, look at the absolute scan times here. We go right down the middle at, running anywhere from 6.5 minute shoulder, 6.5 minute thoracic spine, to a prostate exam with 12 minutes and 50 seconds of cumulative scanning. It's pretty remarkable what we can do with this particular innovation. So, what has it meant for us? Well, this particular facility had been running 20-minute appointment slots, and now they're going to 15-minute appointment slots. This is one of the busiest scanners in Manhattan that pretty much scans a long day. So you can imagine with this particular innovation, we can add 1 more patient per hour. That's going to be about 10 more patients per day. And we fully expect to see this realization in terms of volume because it's such a busy facility. In other regions, we might be at 30-minute slots. This will take us to 20-minute slots. In each case, we're running an increased efficiency of about 33 to 50%. And frankly, aside from the throughput benefits, there is improved operational consistency. It allows us to stay on schedule. It gives us a greater ability to accommodate add-ons and the typical disruptions that will always come up with insurance pre-certifications and implanted devices, and certainly will keep us on schedule and allow us to reduce our overtime needs. So I'm glad to have made my contribution to this program. Just to summarize in my few minutes, this is a tool that elevates image quality. Of course, it reduces image noise. It has the ability to recognize and mitigate artifacts. The acceleration and noise reduction in this tool allows us and encourages us to use higher matrices or higher resolution approaches. Along with the acceleration techniques like reducing necks, it actually enables acceleration techniques that actually can improve the integrity of the target image, like reducing blur and increasing sharpness. And in general, when you reduce the scan time, you should and do reduce motion artifact for the most part. And as you heard in my final slides, substantially improves the patient experience and throughput from about 33 to 50% in real practice. So I hope you enjoy the rest of the program, and thank you for your attention.
Good morning. I'm Dr. Randall Stenoien. I'm a radiologist in private practice here in Houston, Texas. And I want to talk about a little different aspect of Air Recon DL, and that is return of investment. My group, we're comprised of radiologists. We're radiologist owned, we're radiologist operated. At the same time, we have to pay our bills. And so whenever we make a decision, there's a business aspect to that decision of how is this going to work out financially for the group, and is this the smart thing to do? In the outpatient world, there are challenges to reimbursement. The hospitals tend to, particularly with the payers, have a substantially higher reimbursement rate than we do. And so our fee schedules are substantially lower than those we're competing with. And that in my case, is the Texas Medical Center, Methodist, MD Anderson, Herman Memorial. And so when we make a decision to purchase a new piece of equipment, particularly an expensive piece of equipment, we have to be very thoughtful on how we do it, how we time it, and then make sure that we can pay for it. I found that in my practice, the secret to my financial survival has been the fact that we're able to do more complex exams, and specifically exams that require contrast, body exams, a lot of abdomens, a lot of prostate work, high-end neuro work. The reimbursement from the perspective of an outpatient radiologist is on the order of 2 times the reimbursement. The upside is you get paid more. The downside is that these exams are substantially more time intensive, and the slots are much longer. So what we decided a year ago was to open a new center, and specifically this is in Pearland, Texas. We opened it in October. We had a timeline of approximately 12 months to profitability, and I had a pretty good plan. Well, of course, along came COVID, and in March of this year, we closed the center. We dropped our clinic volumes had dropped to about 20%. We closed 4 of our 6 centers for a period of 4 to 6 weeks until we could kind of weather the storm and then really figure out how we were going to come out of this acute crisis in the spring. So my 12-month plan to break even and eventual profitability was clearly dashed. Happy with the scans. We opened up again. We're doing 6 to 8 to 10 studies a day, but still not quite there. When I was approached by GE and they told me about Recon, I had experience with image acceleration and image deep learning with a third party, but recognized that this was potentially going to be very special in terms of the quality, in terms of the image acceleration. And while I listened to the presentation for 45 minutes, within about 3 to 5 minutes, I knew that this was probably the best thing to do. And so we went ahead and adopted the technology. We were told apparently that we needed to schedule a day of training, not to schedule any patients. As it turned out, we had 14 patients on the schedule when GE showed up to set up our applications, and we just started on the fly. And the real beauty of this is that as we set up these protocols, and we were doing it one by one as our patients came through, we set up protocols immediately. The image quality was fantastic. Immediately, the scan times were decreased. I think if you look at the times here, you'll be pretty impressed. MRI of the hand, original scan time of 31 minutes down to 12 minutes for a 60% reduction in savings and better image quality. One of our first patients was a pituitary scan. Again, 30 minutes, 40 seconds on the same scanner. We scanned the patient in January. We scanned them again that first day of imaging with a 14-minute and 42-second scan time, so a 52% reduction. And when I sent those images to my neuroradiologist, I immediately got a phone call to ask what in the world had happened. It was the prettiest pituitary scan she'd ever seen. Our knees were already quick, 13 minutes down to 10 minutes. As you can see, a complete head, cervical spine, thoracic spine, which is our MS protocol, we dropped it about 30%. Prostates from 27 minutes to 16 minutes, and those imaging times are going to decrease further once we get to some diffusion protocols, which we hope will be released in the first quarter. We don't need to go through every single image parameter, but just recognize that on average, we've got about a 50% savings in scan time. And what that means is that for many of our patients, it takes nearly as long to prepare them, get them on the table, get them off the table, and clean the table as it does to do the scan. How did this affect our profitability? And that's probably, to me, the most compelling part of the story, is we went live the end of September. And prior to going live, we were doing, on average, 10 to 12 patients a day. Immediately with the Pioneer, with Recon DL, we were able to add 4 time slots a day on average. And the reimbursement data is not linear. But I will say, if you look at the revenue per month, the difference in revenue was immediately accretive. And October of 2020 was indeed the first month that we went into the black. We not only broke even, but we were able to make some money. So return on investment, we've accelerated my time to break even and indeed profitability. And there's a lot more to run. I mean, we're running an 8 to 10 hour day. As we come out of COVID, as the volumes increase further, we're going to have really a tremendous opportunity to be profitable with this magnet. So it's for us, it's been a wonderful experience. It was a turnaround experience at my Pearland Imaging Center, and I'm sure there'll be other opportunities in the future to put in new magnets. Thank you very much.
Great. Well, thank you for those fantastic presentations. Now, I'd like to open it up to our esteemed panelists for an open Q&A discussion. Dr. Stenoien, I'd like to start with you, pick up after your presentation. We talked with you a little bit about a month ago after your initial air coils and Air Recon DL installation and heard your initial feedback. What have you learned now about Air Recon DL now that you've been using it and been up and running for almost 4 months?
You know, the beauty of it is that the learning curve was so rapid that we adopted our protocols immediately. We moved forward. We really haven't had to change much in the way of protocols. We really haven't changed the timer of the acquisition. So we had a pretty quick, rapid improvement in imaging time, imaging quality. At that point, we've kind of stayed stable. I mean, we occasionally get a new study. We occasionally will kind of finesse exactly how we want to do specific aspects. But I mean, the amazing thing is that there hasn't been much of a ramp up. The ramp up was immediate. The effect was immediate. And as you saw from, the ROI, I mean, we were right away increasing our patient load by 50%. So that's a nice thing. I'm looking forward to some of the new protocols in terms of diffusion, which will help my prostate imaging, but that's probably coming up in first quarter. That's very exciting to me.
The ramp up time. I'd like to ask a similar question to Dr. Allers about the ease of use. How have your radiographers adapted to the use of Air Recon DL, and what was the ramp up time at your institution, Dr. Allers?
When we started going into clinical routine after application, the first thing, there was a big wow from the techs. And after that, we haven't switched it off. So also in our case, no learning curve. So we've adapted it in as many protocols as possible in a very short time. And in fact, we did some protocol optimizations and saved some scan time doing so. And the techs appreciated the beauty of the images, the image quality very much.
Dr. Allers, are you still finding the need to reconstruct the images with and without Air Recon DL?
In the beginning, we pushed the original reconstructions to the PACS, but we don't do it anymore. So I wouldn't refer to them for clinical purposes, just in order to show maybe the difference between conventional reconstruction and deep learning reconstruction. But from a clinical perspective, I wouldn't need the originals anymore.
Mm-hmm. Great, thank you. Yeah, Dr. Atkins, can you comment on your own level of clinical confidence now that you've used Air Recon DL for a while, and also say a bit more about what your referring physicians may have said about and what the feedback has been about the image quality?
So the feedback on the image quality has been excellent. We also have stopped reconstructing with and without Air Recon DL for quite some time now, actually for a number of months. And our referring physicians they're aware that we have this new technology, especially in the musculoskeletal space. Our main chief of musculoskeletal imaging has distributed some of these images, and he's really, really happy with them. And we've decreased some slot time as well, which was a problem for us previously with musculoskeletal imaging. We were running into some longer slot time. So I think across the board, we've been really, really happy with the technology and adopted it in every in all of MR. Our neuroradiologists feel the same way as we do.
Mm-hmm. And Dr. Tannenbaum, you showed us a number of really nice cases. Can you comment on what anatomy you think benefits the most from Air Recon DL? In your experience?
Human anatomy. I think human anatomy benefits the most, I think, in general. Honestly, it's such a revolutionary change in the look of the image and what we can deliver in terms of signal to noise and contrast to noise and just curb appeal. I actually believe in my soul that these images are less taxing on the radiologist to read. And I also believe in my soul that when you raise the spatial resolution and decrease the noise, you do detect disease in a more facile fashion. So honestly, I don't know that there's anything that isn't well adapted to this. I mean, honestly, it would be nice to have non-Cartesian sequences available and 3D acquisitions available. But reality is roughly 90% of what I do, fits into what we're doing, and it's made an enormous difference. And I don't think there's any area where I would shy away from using it and aggressively employing its capabilities.
So you've been around MR for a while, Dr. Tannenbaum. How would you characterize this technology in your experience with MR so far?
Well, honestly, I've been around for 30 plus years, and I've lived through a number of generations. As a matter of fact, I believe I started working on a 2X GE system, which was a two-step to Performance Plus. And that was a long time ago. And I've lived through everything from the routine systems to broadband coils and phased array coils and the like. Experience firsthand what diffusion, how diffusion changed MR. There's no question this is the most revolutionary development in clinical imaging that I've experienced, and certainly in MR. This has completely changed the game in a way that high channel count coils, parallel imaging, other things just couldn't do. So honestly, this is a revolutionary change. I look forward to getting it throughout our network, and honestly, the MR world will never be the same after this, because patients are going to become accustomed to being on and off the table in less than 10 minutes, and we'll deliver better quality than we ever have before.
Wow. Powerful words indeed. That's a true testament to what this technology is bringing. Doctors, we talked a little bit about the ease of reading these images. Can you speak about your impression of whether this has affected your exam reporting times or your the ease of which with which you read the images, or you and your colleagues read the images?
So in terms of reading of the images, I would say that the improved contrast to noise ratio definitely allows easier depiction of lesions. It enhances lesion conspicuity, and also beyond that, it just is more fun to look at these beautiful images, and it's really giving us less eye fatigue, because it's just, as Dr. Tannenbaum said, it's just much easier to read them. And so I personally find it less exhausting. So it's just easier to do, to read through these beautiful images.
Mm-hmm. And Dr. Atkins, you also showed great examples across different anatomies. Can you talk about how your institution is trading off the approach of going for higher resolution or improving scan time, or a mix of both? And does that depend on the anatomy?
So it definitely depends on the anatomy. During COVID times, we've used the time savings actually for improved cleaning in the MR scanner. So Air Recon DL came at a perfect time, because we needed a few more minutes to wipe down the MR scanner. But in the future, when we're not in COVID times, we hope to use it for scan time reduction. Our slots we haven't reduced yet due to that, but certainly we plan to. And in body imaging specifically, we have utilized the technology for a combination of improving image time and certainly SNR improvements, image quality. Overall, I'd say probably in our body imaging slots, our rectal cancers, prostates, et cetera, have the image times or the scan times overall about 10 minutes decrease per patient minimum. And so we've really been able to utilize that time now for cleaning, but in the future we'll plan to use that for more slot time.
Mm-hmm. And Dr. Stenoien, how about you? How has COVID affected your practice, and has Air Recon DL helped you?
Because of COVID, we're not as busy as we might be otherwise. And in the outpatient world, we don't always control our patients' arrival times. There's increased times for screening. There's a little bit of increased prep time. And yeah, indeed, there is increased time to sanitize the room. So what it helps us to do is to stay on schedule. I could be more aggressive in terms of my slots, but at this point, I'm pretty comfortable where they are. Patients are not having to wait a long time. The scan times are very short. The image quality is fantastic. So we've got really good customer service during a pretty stressful time for all of us. I mean, all of us, our patients, our employees. But I see in the future really the advantage to ramp up the efficiency of the scanner. And when you can have two scanners together, in some of our imaging centers, we're small, but we've got a couple of imaging centers with two MRIs. When you've got two scanners that are very, very quick, you can account for load balancing, and you can get very, very aggressive with your slots. So as we come out of COVID and as we get busier, it's going to be fun to see how we can make this thing hum in terms of patient throughput.
Mm-hmm. This is an open question. Have any of you used Recon DL on follow-up exams and looked at the, before Recon DL and after, once the patient has come back? Have the patients noticed any shorter scan times or given any feedback?
Well, I would say that we have used it on people that have been in the scanner before. Not necessarily, I don't know that we've really done it for follow-up exams, but I'm sure we have. We do get very positive comments from our patients when they get off the machine earlier. And we've seen that with every innovation, but patients are very, very sensitive how long they spend in the bore. We tend to be inured to this concern because we're not at the scanner and we're sort of used to the environment, but patients don't like it in there. About 30% of patients report real anxiety reactions. These are ones who go through the examination. So anything we can do to shorten the experience is a plus for the patients, and we're very heavily invested in that in a number of different ways, and patients notice it. They really do. Mm-hmm. Our internal difference of 2 or 3 minutes on a statistically significant basis. So this really has the potential to reduce the table times as much as you heard, as much as 10 minutes in some institutions, and that's a big deal.
Mm-hmm.
We've had very similar feedback with our new MR center and advent of air coils and free breathing examinations in body imaging. We've had a number of good feedback from patients, and now that we're decreasing their table time, they're even happier. We've done a number of our oncology patients who've come back through multiple exams now that we're about 6 months plus into Recon DL with faster scan times. And same with Larry, patients are just happier when they don't have to hold their breath and they can spend less time in the MR scanner.
Just a kind of a humorous note, our grumpiest patients are the grumpy old men who come in for their prostate MRIs. And I'm thinking of using that as just a little bit of propaganda, a little bit of advertising, because they're a lot less grumpy when they're out of the scanner in less than 20 minutes.
I would think it's not easy to tell whether you've been in there for 4, 5, or 6 minutes. It's probably hard to tell. But I expect that we will see less scan interruptions. So from the experience, there are a number of exams where patients interrupt the examination due to pain or anxiety. And I think if we've done in the time that normally is being used for 2 series, and we've done with the 4, this will be an impact.
Mm-hmm. Right. And Dr. Allers, follow up for you. What advice would you have for sites who are just beginning to adopt this technology?
Well, I think if you just switch it on, you will get really beautiful images, and this is you gain a lot by just doing this. But the main fact is to optimize the protocols, as I showed, to iteratively go and adjust your sequence parameters in order to increase the spatial resolution, in order to decrease the scan time, or even to push into areas where you couldn't go before. As I showed in cardiac, for example, reduce or increasing the spatial resolution to get rid of certain artifacts is just been enabled by the use of the deep learning reconstruction. And so my advice is to look at your protocols, to see what you can improve in terms of resolution, and get as many scan times out there as possible. And then any noise you introduce, just remove it by switching DLR to high.
And Dr. Tenenbaum, can you comment on your level of clinical confidence when using Air Recon DL? Have you had any concerns about image quality or cases where there was some ambiguity using Air Recon DL?
Well, we did a couple of research studies on Air Recon DL, and in the research studies, we challenged our readers to look for aberrations. Is there something weird happening here? Because, you know, in the data science field, taken to severe extremes, you can introduce some weirdness in DL processed images. We're nowhere near that here, but we did challenge our readers to look for aberrations, and we didn't see any. With that in mind. Now, honestly, images that are easier to read, as you've heard, with better contrast to noise and better spatial resolution, there's no question your confidence is higher than it's been, ever in the past. Honestly, you sit down in front of an image with high curve appeal, and the tension just comes right out of your body. It's a beautiful experience. Comparing that to, say, on my mental impression of our most challenging exams with poor SNR, in a variety of different settings over the years, you sit down to a beautiful study, and all is good with the world. So honestly, confidence is higher than it's ever been.
Fantastic. And what advice would you have, Dr. Tenenbaum, for new users of Air Recon DL?
Turn it on. Tune in, turn on. What is the expression? Tune in, turn on, drop out. Is that the way it works? Well, just turn it on. Fundamentally, I actually think that if you in our early experience with Air Recon DL, the first research we did was just turning it on. We didn't change anything. So we actually looked at a lot of experience with just comparing things with and without, with no changes. And honestly, that works really well. But it's a missed opportunity. I think you heard. We heard just before wonderful suggestions as to how to use the tool and leverage its abilities to inherently sharpen, to allow your dreams to extend into higher resolutions than were ever practical beforehand, better patient experience. Honestly, just the real cleverness actually comes in as to how you accelerate when you're already got a high channel count coil and you're down at 1 or 2 necks anyway. Where are the areas to accelerate? And I think there are clever ways to do it. It's a bit intricate when you get beyond 1 or 2 necks. And but I actually think that do what you can, get the quickest accelerations you can get with reduced necks, and then start dreaming. I think this is an opportunity to dream. And I think, listening to my co-panelists, it seems like there's a fair amount of dreaming going on, because honestly, the first pass at this is not going to be the last pass. I think the entire field is going to advance when we realize what this capability is going to bring us. It'll go well beyond the pedestrian steps that we've taken into, I think, a significant generational shift in terms of what MR can produce.
Thank you so much. I think on that note, we will conclude our Q&A panel discussion. Thank you so much for your comments and for your presentations today. Thank you all.